Hello.
Hi.
Hey, it's
Hey.
Tatiana.
Hey, it's Esther.
How are you guys? I don't see anybody, but I hear you.
Same.
Hey
Did you,
guys, here we'll pop on for a really quick video, and so we could just turn that on. And I think we're in good shape. The live stream is actually going, and so in just about 5 minutes, I can do a quick intro, and I think we're just waiting for Emily to sign on.
okay.
Should we be able to see more than just you, Gabe, or only you at this point?
I think just me, and then I will bring Esther and Eric and Emily up as panelists after I do my intro.
Okay. So when you want me to be fielding questions from the YouTube to you guys, this is the place you want me to be typing them, the chat here in the Zoom, right?
Perfect. Yeah, that's
Okay.
exactly it. Yep.
Okay. All right. Am I visible on here? Because I'm trying to use a second device to be able to use YouTube without, I can't have it like on the same screen. Am I visible or not visible?
So we can see you in the chat, but we don't see like a picture of you.
Okay. Okay. That's
I
fine.
don't see you, Tatiana. This is Sanjay. I'm excited for everybody. And Tatiana, I can't see you right now.
Okay. Yeah, I don't care either one, but right now it looks like I'm zoned out playing on my phone when I'm really trying to get into the YouTube. So I just wanted to, trying to be
No,
mindful.
you guys are perfect. That's perfect.
Okay.
Yeah, the view we have, Gabe, just so I can't see anybody except for you. You can't see even who else is a panelist, actually.
Right.
Right, and that's on purpose, Sanjay. Good
Yeah,
catch.
no, I know. I'm just informing. Yeah, no, I get. I just wanted to make sure you knew what we were seeing. But
Yeah, and if that happens actually after I do my intro, please stop me and we'll make sure to get everybody on there, because no one wants to see just a lot of me tonight. My part should be very short. Let's see here. Do you guys see Emily? That's what I'm looking for. There's Jenny, Brian.
Unknown caller.
Looking good there, Gabe. I'm impressed. Your lighting is phenomenal.
Yeah, you look
Clean up all right.
great.
Yeah, totally.
I was thinking the same thing.
How did you get that so good? Perfect.
I have been playing with this stuff for a very long time. This is the tech nerd.
Yeah, but even when we play with it, we can't get it good. So you look great.
I could tell you the secrets. So I'm looking for Emily. I think I'm going to send her a text and just make sure everything's okay with her, because as soon as she's here, we can go ahead and like I said, at 5, we'll be ready to go. In fact, I'm going to mute myself because this is streaming, so people are getting a little pre-show right now. Okay, perfect. So Emily's here. So we'll give until 5 o'clock. I'll do my quick intro, and then I will hand it over to our speakers. Okay, we're live and we're rolling. Welcome everyone to the inaugural event town hall launch for Osler's Alliance. We are so grateful for all of you to join us tonight. Just over a year ago, on my journey to try and better understand burnout and see how I might be able to make a difference, I became friends with Dr. Eric Topol. At that time, he told me he was working on a little something, and I've come to know that if Eric tells you something like that, you probably should pay attention. A few months later in August, his landmark piece came out in the New Yorker, arguing that it was time for us as doctors to organize, saying that we needed to come together to stand up for things that we deeply believe in. This resonated deeply with me. And after Eric's piece came out, when he asked me if I would help lead this new organization, I was both surprised and a little taken back. I mean, who was I, as a rural family practice doctor in Montana, to be someone to lead an organization like this and take on that responsibility? But after talking to my friends and family, I simply couldn't say no. It's definitely part of my calling. So here we are. Fast forward to today. For the last year, a group of us has been meeting bi-weekly. We've been having culture meetings and strategy sessions and talking with leaders around the world about how to build the kind of foundation to make the kind of organization that Dr. Topol called for. And we're so proud to be able to launch tonight. I'm really excited that you're all here to join us. A little housekeeping before we jump into the event. It's going to be a 30-minute conversation with Drs. Topol, Chu, and Silverman, and our special guest, Dr. Lena Nguyen, followed by a 20-minute Q&A session after that. So if you're following along on YouTube, please make sure that you leave questions in the chat, because that's where we're going to get questions for the Q&A. Now for the part that you've been waiting for, an introduction to our speakers for tonight. And that's why we're all here. I could not be more honored to be here to welcome to the stage Drs. Esther Chu, Eric Topol, and Emily Silverman, my friends. These folks have accomplishments that are off the charts, and I am totally humbled to have them with us here tonight. In fact, their backgrounds speak for themselves, but what I really admire is that each of them has already made a huge difference toward making medicine better for all of us. I hope you all will help us give a very warm welcome and a thanks to our guests as I turn the stage over to Dr. Emily Silverman to lead our conversation tonight. So give me just a moment and I'll turn this over to our speakers. Thank you from the bottom of my heart. Just a second, it sounds like we're getting some feedback. We'll be right with you.
Sounds like the feedback is gone.
Yeah,
Should we begin?
sure.
Hello, everyone. Hello, Dr. Topol, Dr. Chu, and American physicians. It's such a pleasure to be here today, and I'm really excited to see where this conversation takes us. I'm sitting here in my apartment in San Francisco. You can see it's still light out. Some of you might be in the middle of the country or on the other coast where it's already dark, but either way, it already feels good to all be together. So thank you for joining us, and I look forward to a joyful and aspirational discussion. So let's just start with the simple stuff. Eric, if I might call you Eric.
Of course.
You wrote this article in the New Yorker, Why Doctors Should Organize. And here we are, a group of physicians, Osler's Alliance, What is Osler's Alliance?
Well, first, it's great to be with you, Emily and Esther and Gabe and all the activists that are part of our group and the ones we're going to try to inspire during our first launch meeting today and hopefully for months and years to come. But I think what was really called for is we're in a pretty desperate situation right now, which has been highlighted by the pandemic, that we're not, as physicians, being active enough to make for a better situation. That is the singular purpose of this patient-doctor relationship, to not only be preserved, but to get it back to where it used to be. I'm the old dog in the group, but it used to be a precious, intimate relationship, and it's eroded over time. And that's largely because we haven't stood up, and now is our chance. So that's really what it's about.
Thank you. I love what you're saying about how we have to change to stay the same, which is a phrase that my friend Dave Logan talks about a lot. Changing the organizations and the systems of medicine so that we can get back to our roots, so that we can be the same as we were always meant to be. So thank you. Esther, anything to add to that?
It's muted. Uh-oh.
No.
Oh, now
Oh, we can hear you now. Yep.
Okay. Maybe it was the AirPods. I just turned them off.
All good.
Sorry about that. Well, I'd say the exciting thing for me is I think all of us have kind of floated through medicine and have this feeling that it's just not right. You know, we all just kind of go to work, and 100 times a day, you feel like this can't be the way that it's supposed to be. And yet there's so little empowerment on the level of individuals to feel like they can change anything. And so just the idea that we can be a bunch of very different people with different backgrounds in different places, and that maybe if we came together, we could in aggregate actually make real and palpable change and get us back to more of the picture you had when you went into medicine of really connecting with your patients, and also just having ownership and control about how those interactions should go. I think that's the premise here, and it's an exciting one. And of course, it's a risky one, but I think we all came to the room feeling like it was worth it to try.
There are a couple of words that you just said that really stood out to me, which was ownership and control. And I think that is something I've been thinking a lot about lately. I think in medicine, especially when we're residents, we're showing up when we're told and where we're told, and you have to work this shift for this many hours, and the match is something that feels very out of our control, where we uproot our lives and entrust our futures to a computer algorithm, go to strange places. So it feels like there is a way in which a lack of control starts in medicine very early. And so I'm wondering if either of you would like to talk a little bit more about this lack of agency, or this feeling that we're not sort of holding the reins of our own destiny in medicine.
Well, I can start in just that if you've seen, of course, what's happened in the last couple of decades, it's been a growth of healthcare people, but they're not on the front lines. They're not physicians and nurses and healthcare professionals, but rather the back office to promote the business of medicine. And we've seen that play out too when we needed PPE and the things that were prioritized in recent months this year. We've lost control. And basically we're managed, and we have overlords, and that shouldn't happen. And if we stand up on the for the purpose of patients and our connection, and Gabe was the one that had to fight burnout. The burnout largely reflects this loss of control and inability to provide care. So I hope that these efforts can really start to push us in that direction.
Yeah, I agree. And I also want to say that, part of what keeps us from feeling empowered is the solutions seem too big. I mean, I'm seeing a comment from the chat that like nothing can change until, you know, we really fundamentally change our system of insurers controlling doctors and making obscene profits. And, you know, like Eric said, this really bloated top-down environment we have. And I think that's exactly it. I think we're getting together to say, rather than feeling futility all the time, how do we get to those fundamental problems? You know, how do we advocate for actually fundamental change in the way things are done, even if that leads us to a path of you know, of advocating for restructuring? I think we're coming to the table saying that that we need to really understand, you know, all of our options and figure out where we can be effective working across stakeholders and levers in medicine, and really just figuring out what are some solutions that we as a group can push for, again, on the premise that if there are enough of us in the room and we're dedicated to never stopping until we find effective solutions, then maybe we can actually do something. So I know it seems intimidating and what we're taking on seems kind of shockingly big, but I think we really feel like everything's on the table, and we just want to start somewhere.
I love what you said about how we shouldn't be afraid, because if we look around, we see that the status quo is not working. It's just not working. And so how do we talk about fundamental change, restructuring? How do we get imaginative and get creative and really tap into that ability for us to dream and to tap into our desires as healers, you know, as people who went into medicine for the right reasons to take care of patients? So I just find that personally really inspiring. I did want to ask about this idea that Osler's Alliance will be a timeless organization, and how that might distinguish it from other physician organizations that are in existence. Could you speak to that? What does it mean to be a timeless organization? I love that.
Well, you know, I think that we were trained to keep our head down and take care of patients. And it kind of like, you know, telling LeBron James, just shut up and dribble. And, you know, I'm actually with a couple of the leading activists of our times in medicine. I don't know anybody who does more than Esther and all her efforts. And then Emily, with you and the Nocturnus, you set examples of what we can do that's beyond the care of patients. And the timelessness here, it relates to the ability to step out of our comfort zone, which has been patient care, but for the years ahead to not be subjugated to the way medicine is today, which has just led to this erosion, this remarkable erosion of way it should be, and why we've lost our purpose. That is, all of us went into this profession to care for patients. And if you can't care for them, no wonder there's such profound disillusionment. So it's timeless because this is the essence of medicine, and we need to reestablish it.
Great. Yeah, there was a word you used there, subjugate, that I thought was really interesting, just because you talk about how shut up and dribble, we have our heads down, we're taking care of patients, we're doing our jobs, and there's this administrative creep, and there's, you know, all of these things that seem to be happening to us, and we just keep taking it and taking it and taking it, which makes sense because the way that we got to where we are is to be obedient and to follow the rules and to have our face in the book and to get the straight A's. And, you know, in medical school, they teach you about the Krebs cycle and the renin-aldosterone pathway and things like that, but they don't really teach you the fundamentals of leadership or how to stage, you know, revolutionary change within an encrusted, calcified healthcare system. So these are not muscles that physicians are used to working. This is not our usual thing. Of course, you know, there are exceptions. There are physician advocates out there, and Esther, you're one of them. I'd be curious to hear what you have to say about this, but it's not our default state. So Esther, I don't know if you have anything to add there.
Yeah, I mean, probably just agreeing with what you both said. I agree. I think there's just lots of ways in which we're inclined to advocate for a lot of things, but leave this fundamental issue untouched. And I mean, I think a lot of our discussions have been why, because the things that we readily agree on are what Eric said about, like, there is this character, this value at the heart of medicine that we probably all experience and would describe and aspire to something a little bit different, but and yet we all kind of know what we're talking about when we talk about humanism in medicine. And I think there's just this thread that has probably been there for all time. And when we talk about kind of the humility, the kind of nobility of the work and how honored we feel to be at the bedside. And even if we can't quite name it, we have a gut connection to it. And why that's the last thing we feel like we can advocate for is really a strange thing. And I think, I think it's really, sometimes change doesn't happen until you've gotten really to a tipping point where it really is no longer acceptable. And hopefully this year, with all the additional stressors of COVID, has made us realize, you know what, this is far enough, and now it's time for something. It's that lovely quote from Wonder Woman, that the male lead in Wonder Woman says, well, when you see something that's wrong, you can either do something or you can do nothing. And I've already tried nothing. So I think that's where we are.
And I think that's a really great thought experiment, just to go down that road a little bit. And again, our friend Dave Logan talks a lot about this idea of the default future. So if we continue to do nothing, what is the fate of American healthcare? What are we slouching toward? What will happen if nothing unexpected comes along, or if doctors don't organize and speak up for the doctor-patient relationship?
Yeah, I think, Emily, the problem is that today, the organizations that exist in medicine, professional societies, they don't have this as their singular purpose. And in fact, you don't even know if it is even on their radar screen, this mission, this singular mission. And so if the default mode here is that things actually could get worse. I mean, it isn't like we're not spending enough time as data clerks dealing with electronic health records and looking at screens and unable to spend more time with patients, which is the beginning of reestablishing the relationship and seeing more patients more quickly, reading more scans or more slides or, just more productivity. When is that going to stop? We have the tools to change that, but they will be used in the wrong way if we don't organize. It's not, we have gravitas working together, major gravitas. So, if we don't get enabled and get the solidarity, or if we just count on existing organizations that are not directed in this way, I think it's just potentially, you'd say, how could it get worse? Well, I think it actually could.
Yeah, and I think COVID has really been that acute on chronic stressor. It has really unmasked a lot of those faults and cracks that existed already in our healthcare system. Esther, you were going to add?
Well, I was looking at questions from the chat, and I think to just give Gamish. I'm so sorry. Alexa is just talking to me next to me. I must have said something that sounds like. Anyway, I think to gamish some of the questions together, they're really about how do we even start on a path this massive, and how can we sort of break it down into doable chunks. I think the way that was framed was really good. I mean, I think our idea is, you can't agitate for things. Somebody mentioned a protest or a strike, and I would say that's not, off the table at some point. But I think the idea is you have to know exactly what you're asking for. And I think our first mission is really to take our fundamental ethos, but then break it down into addressable chunks, meaningful pieces of, kind of bite-sized advocacy that may feel incremental, but then en masse could actually make a difference in our day-to-day. But we're very focused on when we're like, okay, is this on mission or not? We're really starting to get to conversations are like, okay, what would that mean when you literally walk into the room and you're interfacing with a patient that day? Is there a palpable change there? And I agree. It may be that at sometimes you're really focused on the state or the local level at other time. But I think there are, we will really try to draw things. Documentation, I'll say, is something that comes up all the time. There's no escaping documentation demand and how that has really eroded the well-being of physicians. So I think that may not be the most exciting topic, but I think that will clearly be part of our mission because it is such a huge and universal barrier to getting people to connect with patients the way that they want to. So yeah, it's all going to be about chunking it up and kind of addressing the things that really feel amenable to change and that we can advocate for very, very specifically in terms of what we need and the gap between what we need and what we have.
Yes, and I love how you're moving past the complaint or past what isn't working and sort of crashing through that wall and coming out on the other side. Well, what would that look like? How would that play out in the patient room? Because I find that a lot when I'm just talking with my friends and colleagues. We all know it's not working. We all know that it feels like an extractative system, whether it's the physician who feels like they are on an assembly line, more scans and more patients and just every human piece of it being stripped out. But also we know the patients are feeling like they're on an assembly line and that it's just, not feeling like it's grounded in an authentic human connection. And so we know it's not working, but this question of like, okay, well, what is our desire? What is the picture that we want to paint of what it might look like? And again, I don't know the answer to that question, but I think the first step when we come together as physicians is to, as you said, try to imagine what it might be and how do we break it down into the discrete actionable chunks and really push for change on that level. And so we're going to get to the audience Q&A in a minute, but before we do, I just wanted to ask one more question. So the tagline of this organization is reclaiming the soul of medicine, which I love. And so I was wondering if each of you could just take a minute and share what that means to you.
Esther, why don't you go first?
Yeah, I think that can mean what I like about the tagline is I think everyone can see in it what they want to see. And I think, we've spent a lot of time in this group talking about language. And I think to be cautious with the word reclaiming, we want to reclaim our ideal of medicine. But I think also important in that is recognizing the way in which historically medicine has not been about everybody. I think I was really brought in and tried to serve in this group as someone who is a reminder of that. It's like, we want to reclaim something, but that doesn't mean that we repeat historical aspects of medicine that have not been inclusive of women, of the wide range of rich diversity within our patient populations. And so, yes, we want to reclaim like our ideals of medicine for everybody who came into the specialty. But I think at the same time, we really want to say we are also trying to have a better understanding of what that heart is for our entire body of providers and patients. And so, and so I sort of want to, when I hear the word reclaim, I want to say, yeah, there is an essence of something, but we just want to make sure that that term captures even stuff that we didn't understand was there in the past. Does that make sense?
That sums up well. Emily, I just go back to the earlier point you were asking about what would it look like? And I would say, when you start seeing advertisements for health systems that say, we give the gift of time to patients and clinicians, then you'll know that we're turning the right corner. And that time is equitable across all of our diverse patients and interests. And so I think the problem we have right now is that the soul of medicine has been lost because it became the business of medicine. Back in the ancient days, when I was in medical school in my early training, we had 3 times, if not 4 times, as much time with each patient encounter. And that changed dramatically when we had all these things happen, like RVUs and HMOs and EHRs and all these other things that were bad things that physicians just let them happen serially, one after another. But we are stronger now. We have exemplars, we have social media, and we know what the mission should be and what patients want. And all we have to do is rise to the occasion. And we just have to really take on another dimension of our efforts, which is not just what we're expected to do, but what we can do.
Thank you. Both of those comments went right into my soul, can I say? I mean, I'll just share for a moment that for me, I've been all about storytelling. For those of you who don't know, I run a medical storytelling live show and podcast called The Nocturnist. So I spend a lot of time thinking about storytelling, specifically how it pertains to healthcare, and really how when we're taking care of other human beings, it's not just taking care of their body parts and giving them pills and potions. You really kind of have to meet them where they are and meet them in story and sort of understand kind of how they think of themselves and help guide them along and, engage in deep listening practices and things like that. So how do we accomplish that in a 7-minute visit? It's impossible. And you're right, Eric. We just let this happen. And, the good news is it's not too late. We can rise to the occasion. And I'm just so excited that it's happening and thrilled that all of you in the audience are here. And before we get to the Q&A session, maybe we'll just wrap this portion of the conversation unless there's anything else, Eric or Esther, that you'd like to say.
I just want to share one thing. I had a shift recently with a medical student, and the patient, at the end of her visit, pulled me aside and said, the best care I got today was from that medical student, and told me what he did, which was basically pull up a chair and spend time with her to sort out the issues and to hear with her and make sure that some information got relayed to me. And I thought, I mean, I really pride myself on the efficiency of my practice, at the expense sometimes of other things. And I thought, what is it that med student has that I have clearly lost, and also gotten to the brain space that is okay, and try to remember where I was when I was a student. And I felt so sad because I was so far from understanding. If she hadn't said something, I actually would have felt very proud of how I took care of that patient, because there were a lot of things that I did that would be rewarded by my system. Namely kind of efficiency and productivity around that patient, around that shift. And yet the med student saw his way to something that was much more valuable to the patient. And it made me feel kind of sad and upset and angry, because I think the system creates me. I am a product of the system that we're in. And it felt so disconnected in that moment to what I went into medicine for. And so I think even those of us who are in this conversation all the time still kind of slip into rank and file, and become a product of our circumstances and our system. And that is not a mistake, it's like, it really is one of those things where you're like, it's not a bug, it's a feature. It's exactly, I in some ways have become exactly what we are meant to become, and I don't like it. And I think it can happen passively, without us even realizing it. We can become kind of a cog in the wheel in the machine of profit. And so that was just one of those real, come to Jesus moments where I was like, this cannot be how I end my career. Like, we have to do something about it. Let's end on that note.
Yeah, I love that story. As a patient myself and a human myself, I just know that I want to be seen, I want to be known, I want to be heard. And it sounds like that was something that the med student had the time to do, that unfortunately the rest of us, the way the system is set up, don't. So as you said, Eric, the gift of time. So moving forward, before we get to the Q&A, we have another special guest. This is Dr. Lena Wen. I'll just stop there since I introduced her in the video. But Gabe, would you like to roll the tape of my conversation with Dr. Lena Wen? Hello, world. My name is Dr. Emily Silverman, and I'm a hospitalist at the Zuckerberg San Francisco General Hospital. Today is Thursday, November 19th, and I am sitting here with the amazing Dr. Lena Wen, who is an emergency physician and public health professor at George Washington University. She's a contributing columnist for the Washington Post and an on-air commentator for CNN as a medical analyst. Previously, she served as Baltimore's health commissioner. Thank you so much for joining us today, Lena.
Of course, always happy to join you.
So as you know, we have all come together today because of Eric Topol's article in the New Yorker a while back, which was asking this question about how physicians are really struggling with these problems of burnout, moral distress, disillusionment with the American healthcare system, really feeling like they're not able to connect with their patients or even with themselves in a lot of ways. And so Eric was asking this question of why haven't doctors organized? Why don't we come together and form a single unified voice so that we can influence healthcare? And so that was the birth of this organization, Osler's Alliance, which is a new doctors organization. And there's a group of docs who have started this up and are really hoping just to open a conversation to physicians across America around what's working, what isn't, and how can we come together and advocate for what we feel American healthcare needs. And we're so honored to have you here today. And I would just love to hear you talk a little bit about your experience in American healthcare as a patient, but also as a physician and a professor and as a leader, and what you're seeing, especially with this pandemic, which has unmasked so much of what is wrong with American healthcare, and your vision for where we could go from here, and specifically how an organization like Osler's Alliance might help to facilitate some of that change.
Well, I think you used a word that I just want to spend some time reflecting on, which is the word unmasked. COVID-19 didn't create the many problems that we're now seeing in the American healthcare system. It didn't create health disparities, for example, but it did amplify and unmask existing disparities and these structural inequities that got us to where we are. We have known for a long time about the problems of underinvestment in our public health system. And now we're seeing that come to root. And we're also seeing how there are so many other issues that are intricately tied to health, that housing, for example, is a health issue, food is a health issue. And back to what you were saying at the beginning about burnout, I think so often physicians and clinicians broadly feel this burnout because we went into the health professions, the healing professions, for the right reasons. We want to help our patients. But then when patients come to us with issues that we cannot solve within the four walls of the hospital, we begin to feel helpless. And that helplessness leads to this burnout. And I think this is why coming together as part of a group like the Osler's Alliance is so important, because it is a way for clinicians who are feeling helpless in other ways to come together and make change. And I think that it's also drawing upon all the reasons why we went into medicine, that compassion, the empathy, the desire to help people, recognizing that it's not just healthcare that's going to help people, it's all these other elements in their lives that we have to be involved in too. And I just hope that as Osler's Alliance gets going, that it will be an encompassing coalition, recognizing that physicians also come from very different backgrounds, have different political viewpoints, maybe different personal values, but that there are shared values, so many of them that we have in common, and that people can contribute in different ways. There are people who may be working in organizations that are more conservative. I don't mean in a political sense conservative, but just may not allow them to express their viewpoints in a certain way. They may not be able to go to rallies and speak on national TV about their views, but there are things that they can also contribute to. And where we are at this point in our career is also different from where we might be in a few years' time. And so I think allowing people to contribute however they can, recognizing that patient care is such an important part of the core work that we do. And so embracing all these viewpoints, giving physicians and all healthcare workers a voice at this critical time, I think that's how we can come together and really move the needle on these issues that we care so passionately about, which ultimately center on our patients and the communities that we serve.
Thank you so much, Lena, for that amazing encapsulation of what Osler's Alliance is all about. Is there anything else that you'd like to share with us about where you are right now in terms of American healthcare, dealing with this pandemic, things that you're seeing, things that you would like to see be changed moving forward?
I think all of us are trying our best at this time to get through this current surge. And it's very hard to think medium or longer term when we have people who are dying right now, when we're seeing escalating numbers of cases, when we're shattering new records today and then breaking them again tomorrow. And so I think that we need to get through this current period while also making sure that we do not take our eye off the prize ultimately. the last thing that we want to do is to let this crisis go to waste, so to speak, because there are so many systemic issues that we need to be solving, that we need to continue our journey of fighting for health equity.
Thank you so much, Lena, for speaking with us today. And thank you, Gabe, for bringing us together to talk about the birth of Osler's Alliance.
Wonderful. Thank you, Emily. Thank you, Gabe.
Great, thank you. So now we'll move on to the Q&A portion of the evening. And we have Dr. Tatiana Prowl, who's been looking at all of your comments and is going to be feeding us some questions. So I'll just start by looking at some of the questions here that she posted. So first, there are some questions from people participating this evening who are either patients or who are healthcare practitioners that are not MDs. And the question is, what about us? Specifically the concern, I hope this doesn't become an NP or PA bashing forum. Eric, I see you shaking your head. Do you want to take that one?
No, absolutely not. In standing up for patients, the thought was, as we gathered, was get the physicians on board first, get patients to help advise us, and then as we grow and get influence, just get everybody involved. But the last thing you want to do is bash anyone. That's the whole point. So no, this is really to organize the physicians, get the group of us, get the solidarity and impact started as we grow, hopefully.
Esther, anything to add?
Yeah, I think, the idea was that this would be an extremely collaborative group that brought everybody into the net, but we wanted to make sure that we had the physician's intent right, and that we really drew people in who were really engaged and oriented and would come to the table with that positive orientation, so that we wouldn't, I think just to make sure that that relationship was where it should be and very positively focused. And I do think that when you define a group by any body, like this group is really defined around physicians, it does carry the threat of hearing that we are specifically not about somebody else. And I think that's really on us to make sure that that when you advocate for something positively, it shouldn't be like a zero-sum game where necessarily somebody else loses. And that is something that is very much on our consciousness. And I think we plan to make sure that we understand who we are, and then really work collaboratively with patient advocacy groups, and really every other role in healthcare.
Yeah, so I'm hearing just a real need to have physicians come together first to coalesce and sort of grapple with our own identity and what's going on with us, and then making sure that we have authentic partnerships with other groups so that we're all aligned for a common vision. So thank you. The next question I have here is, what can be done about the EHR burden? And Tatiana says this keeps being asked in the chat. So this is something that came up a lot earlier. What is the solution? Do we get rid of it? Do we work the charting time into our day and demand that that be accounted for, that we get paid for? Dictation, scribes, there's been all these kind of band-aids. What do you all think about that?
Well, there's a technologic solution that we should have had by now, which is synthetic notes from voice, speech to text. And it's already been shown to work really well in many different venues and different specialties. But what we have right now is reliance on human scribes, and there's some 70, 80,000 of them in the country. It's an untenable situation because it then even makes the business of medicine worse. So we have a way out. It is the beginning of seeing AI used in a purposeful way, but the incentive to bring it to reality, the liberation of keyboards, is something we have to push for in our insurance.
Great. Anything to add, Esther? I'm going like this since you're on my right on the screen.
I got the intent. It actually kind of works visually for me too.
Okay.
I think, again, what Eric said, I think use everything that, that is at our disposal to try to reduce that burden. But I also think in general, we think about how do we cope and how do we fix it, you know, for all problems. And this isn't specific to EHR, but I think we really want in this group to be creative thinkers. And I think, you know, taking full advantage of technology, but then also asking what is the fundamental issues behind something like charting, you know? Should there be something we're advocating for so that we can measure quality and safety and transmit information to other healthcare providers without just keep on saying, well, then chart more thoroughly, you know, make sure you capture all these elements, 7 of these and 3 of these, and, you know, all this like sort of constant counting and tallying of what you have in a note, again, feels so far from what we're fundamentally trying to do. I mean, the fact that I ever go back in the chart and make sure that I've captured a minimum 4 elements so that I can reach a certain charting level and that has been programmed into my brain is one that is just, I never would have guessed if you asked me 20 years ago that was a skill set that I would have that has been driven into my brain. And so can we go back to that fundamental thing of why are we doing this? And how does that serve the patient? I think really sky's the limit in terms of the levels at which we advocate to change that. And again, the pandemic has shown us that, I mean, you know, in terms of what we can bill for, you know, charting burden and requirements for hospitals that are overburdened, we have seen things change in this moment. And I think it shows that all things are possible. We just have to know what the, you know, what the incentives are to change and how to put that kind of pressure on.
Thank you. Yeah, speaking for myself, I mean, I like to type it out the story. So I think it's different solutions for different people. I really view it as a storytelling tool where I'm telling a story, not just to communicate to another physician, but to communicate to myself when I come back and read the chart later. But again, how do we make the notes crisp, clean, lean? How do we eliminate all the garbage? Lots of different possibilities. And I love what you said, Esther, about really getting to the fundamental and philosophical question of like, what purpose does this serve? And just really questioning the underlying premises of the practice and starting like super proximal and then going from there is a conversation I think that we as Osler's Alliance should be having internally before we come up with a set of concrete asks. So the next question here from Tatiana is, or that Tatiana is relaying from the group is, how does Osler's Alliance fit within a potential universal healthcare model?
Well, we sure want that. We need that. The pandemic has laid bare what happens when you don't have a universal health care in a country. So, you know, that would be in the interest of I would think, Ulcers Alliance and patients and all the people we can bring into this concept that are long overdue to have that it's a human right. It's something that has been denied in this country somehow, but it has to be turned around. And Esther, we haven't talked about that. What do you think?
Yeah, we haven't explicitly talked about it because I think we just didn't see ourselves as being kind of oriented around changing, you know, healthcare models like that. But I think fundamental to our conversations is we can't fix much at the interface of physicians and patients if the patients can't even get into the room. Because they have no access to healthcare. So I feel like it's very, it's at one with our mission. And I actually think also it's something that can really erode that relationship. If patients are so stressed about paying for that visit, they can't even really engage with you because that just, you know, just coming to see you is so stressful. And what you might advise is so stressful and such a financial burden. But yeah, I think we're probably on the same page with that.
Certainly, yeah, I think there's just a lot of rich conversation there that we can have as an organization, especially as we try to come together and come up with shared values around, you know, people not going bankrupt because of healthcare issues, people having access to high quality care, and that being, you know, something that everybody in our nation should have, being the developed, you know, wealthy, innovative nation that it is. I'm scrolling back into the comments here to look at some of the other ones. And there's just a comment that says, some patients in the chat are saying that medicine is not serving them. And apparently us either, I think us meaning us physicians. And for the patients who said that in the chat, we are not happy either. We are with you. Eric and Esther, I don't know if you want to reiterate anything here.
No, it's just what you say. I mean, I think again, it's very strange, isn't it? For 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 us to be here saying that, we're not at the bedside in the way that we want to be, and then for patients to say, I've come to healthcare and it's not what the experience that I wanted to be either. I mean, if we're in agreement, then how can the fundamental dyad be in agreement, and yet neither of us can get to where we want to be? I think is articulating the frustration and the origin of this group perfectly. So I don't know what else to say except that's exactly.
Well, and we're all patients. I mean, I've experienced it myself, the horrendous situation that we're dealing with and that we must do something about. We just can't sit idle and watch what's happening now. Uh, and most patients are roughed up these days, one way or another, because of the way medicine has eroded. We can do better than this, I'm sure. And all of us would want that, not just for our patients, for ourselves, for our family. So there's no question that it's unidirectional. That's why it's worth putting in the energy to make it better and getting patients involved with Ulcers Alliance once we get a critical mass. So we've got some, real traction, real momentum.
Great. Next question is, can you speak to the burdens of prior auths and peer-to-peer for treatments or studies that are clearly standard of care and will ultimately be provided, but create stress for both doctors and patients?
Maybe you should take a shot at that, Emily.
Well, look, I'm a hospitalist at Zuckerberg San Francisco General Hospital, so I don't do a lot of outpatient work. I don't have to, I'm not a subspecialist, so I'm not dealing with submitting prior auths for, infusions and other things like that. But all I can say is that what I hear from my peers and my colleagues who do work in those scenarios is that the red tape and the amount of administrative work and begging and pleading and just kind of justification to do what we feel is clinically appropriate really eats into the day, and it slows down care, it slows down our day, and it hinders treatment. And so that's not something that I've experienced personally, but and I don't know, Esther, if that's something you've experienced, but certainly I'm sure Gabe has some more experience in this realm since he's a Montana rural doc. But Esther, anything to add?
Yeah, I mean, again, I'm an ER doc, so I don't spend a lot of time in there, but I am also a researcher, and I study health policy changes, particularly those that are administered through Medicaid. And I will tell you, in fact, exactly what I'm studying right now is how a policy that was meant to deliver better evidence-based treatments to Medicaid patients with back pain, how that policy was implemented across the state, and its impact on providers and on patients. And what we find is exactly what this question is getting at, which was that you can say, that our goal is to improve delivery of these evidence-based treatments to patients, but in practice, there's such an incentive to limit access to treatments that that people found that it was such an administrative burden that it was hard to comply with the policy. And then clearly, when you study these kinds of policies, there's all kinds of reorientation around access when there's too much provided, and they're worried about cost. So then you start building in these prior auths to treatments that the spirit of the policy is to get these treatments to patients. And the prior authorization is built in specifically as a strategy to limit costs above access and to prioritize costs above access for patients. So I think I've seen this play out on a policy level. That narrative, sometimes like there's a narrative that is just kind of writ large across the the data, and that is one of those things. And so again, it comes back to this idea that we're kind of not oriented around the needs of the patients, and again, the need to kind of unpack that a little bit and try to figure out how can we make even when we say we're going to change policy around patients, so that they have better access, and then we kind of try to deliver those literally to them in with these big sweeping measures. It's like we also have to build in protections all the time to make sure that it functionally happens. So I mean, these changes that we're trying to make are not, they're not small, they're not simple, and even the best of intentions can sometimes fall apart. So clearly those are tools that have a very specific intent. And I know that physicians feel like, why am I asking permission from a peer who knows 100% less about my patient than I do? You see that frustration boil on social media. I've had people reach out and ask me to try to petition on social media and ensure to approve something that no one could explain why that thing was denied, because it is a single med that has actually worked for them for a chronic condition that has worked for them forever. Then all of a sudden they have to ask special permission from a non-specialist who doesn't even understand the indication for that medication. You see it all the time. So
Yeah, I mean, this is what is detracting further from the patient-physician relationship. I mean, when I want to get a PCSK9 inhibitor for a patient with uncontrolled cholesterol, LDL, I've got to go through this. I want to get a scan, a CT or an MRI of a patient with approvals. I mean, these are ridiculous. Again, we don't have an organization that stands up for this, the time that's taken away from care of patients for this complete waste and unnecessary dimension of our lives. So it's just one of the many things that are interfering that need to get improved for sure.
Thank you, both of you. And we have a note here from Brian Dixon, another member of Osler's Alliance founding team. He says, as an outpatient psychiatrist, prior auths and peer-to-peer are, if I can pronounce this, obfuscation at its finest and only hurt the patient-physician relationship. Thank you, Brian. So I guess, let's see, it's 4:52 Pacific. Maybe we'll have time for one more question. Let's see if I can scroll up. It looks like we have a comment about things doctors are forced to do that don't actually enhance their knowledge or improve care, not just clicking boxes in the EHR, but documenting elements of our exam that have not been shown to improve patient outcomes. This comes to mind just thinking about documenting the review of systems as a hospitalist, which it feels like I have to go back to the room and ask the patient all these questions, not because I care, but because I have to say in my note that I asked those questions in order for things to be billed properly. Esther, you already talked a little bit about this, but if anyone has things to add there. Crickets.
It's a good comment. I mean, it's a very valid comment. And this is exactly why we're having this session, is because we want to know what people feel like are obstacles to providing the kind of care that they would like to deliver.
Great.
Just think if we had hundreds of thousands of physicians in this country to weigh in on this, and they knew that that was our mission, was to make it better, which we don't have right now. It wouldn't take much to do it. I mean, a Zoom call like this and exchanging ideas through emails and social media, and we could start to really get this thing going. And it's just waiting to happen, really.
Great. Well, I see Gabe has reappeared with his Osler's Alliance background. So that's my cue just to say thank you so much to you, Eric, for not just being here today, but for writing the essay, the call to adventure that inspired this all. And to you, Esther, I've just been such an admirer of you for so long, and your advocacy work, your amazing science communication chops and ability to sort of convey messages to the general public. Really, really fabulous, fantastic, amazing. And with that, I will hand the mic back over to Gabe. Gabe, thank you so much.
Thank you, Emily and Eric and Esther. That I could not be more pleased to be here today, and just such sincere appreciation for everybody helping us get to this point. You'll see me adding some more people to the video, and actually this is part of the what's next, because who you're seeing are some of the folks that have been with us for the last year, working so hard to make this possible. So I'm just going to go around briefly and introduce everyone. You've met Eric and Esther and Emily, but we've got Ashley Rodriguez, Brian Dixon, Scott Giberson, Sanjay Desai, Shivani Parikh, Tatiana Prowl, Dave Logan, and Jenny Miladenovic. And I think that let's make sure that I've got enough. Is anybody, did I miss someone that's not on my screen right now? We have a fantastic team of people, and so I guess what I'm trying to show here is that this is how it starts. This is how the movement starts. People coming together and saying, we really believe in something better and we want something better to happen. And so this is the beginning, and we want to hear from you and we want to bring you in. And so we've got a website. We're very active on Twitter. Please come join us at oslersalliance.org. There you can sign up, be a member, get on our mailing list, tell your friends about it. If you'd like to make a donation, you can do that. We really just want to get the ball rolling, and that's why we're here. So thanks again to our wonderful speakers. Thanks again to Dr. Lena Nguyen. And I just want to say thanks to so many of the folks that have allowed us to be here today, and to you for watching.
And Gabe, do you want to share the slide where it's the call to action?
I did want to, but actually, technically, there's been a little bit of a glitch. So this is what you get. You get a Brady Bunch picture of all of us at the end, waving goodbye and saying, "Thank you, come join us."
Well, it looks like there's a couple of questions in the chat. How do we come together? What are the dues? How will we meet? So I can just briefly touch on a few of those and then pass it back over to Gabe. So there's a social network. It's a Mighty network. And to become a member, it's $5 a year. And Gabe, maybe you can expound on that.
Yeah, so that's really our first way to just bring people together. So it's a simple way for us to get together. There's a chat system. We've started some conversation threads there. We're really experimenting with what's going to help get our voices heard and what are the messages that need to be amplified. But if you're interested, please join the Mighty Network. It's intentionally low cost to show that this is not about the money. It's about bringing us together for change.
And med students, I see there's a follow-up. Med students are welcome. And then Gabe, where can they find you? What's the website?
So oslersalliance.org, oslersalliance.org. And you can find us through Twitter. If you look at Eric's Twitter or Esther's or Emily's or mine or anyone on here, I'm sure you can easily find Osler's Alliance. We're also at Osler's Alliance.
Great.
Okay, cool.
I would just also want to say, Gabe, we're indebted to you. There you are, the rural family physician in Montana who've been fighting burnout for years, who made T-shirts, Fight Burnout, how we first got together. Now you're making T-shirts for Osler's Alliance.
Yay.
You're an amazing force. We're indebted to you for all your efforts in pushing this forward. And, we're all going to work together and make this thing happen. So thanks, Gabe.
Thank you so much, Eric. And it means so much to me to be a part of this group because I know we are going to make a difference. Okay, that's it, everyone. Thank you.